Hello guys, I am Deepak Shukla. Welcome to our channel Study Mania. Today let's learn about Meniere's disease, a disease of the inner ear. Meniere's disease is a disorder characterized by VST. You have to remember in this sequence only. V stands for vertigo, S stands for fluctuating sensory neural hearing loss, T stands for tinnitus, and then oral fullness. VST. Vertigo, that is spontaneous attacks of vertigo. S, that is fluctuating sensory neural hearing loss, tinnitus, and then oral fullness. Okay. Let's see little bit of anatomy. Okay. So in inner ear we have bony labyrinth, and inside that we have membranous labyrinth. Okay, bony labyrinth we have vestibule. Posterior to that we have semicircular canal, and anterior to that we have cochlea. Okay, so suppose this is vestibule, and posterior to this we have semicircular canal, and anterior to this we have cochlea. Okay, now in vestibule we have saccule and utricle, and this anteriorly we have cochlea. So in cochlea we have cochlear duct. Okay, this cochlear duct will unite and meet in the saccule and utricle, and these together will form a shunt that is called endolymphatic sac. Okay, endolymphatic sac, making a passage for the endolymph to flow. Okay, now let's see what is endolymph. So endolymph is present inside the membrane. Endo means under, and inside the membranous labyrinth. Simple. It is produced from cochlear duct. And it is secreted by stria vascularis. Whereas perilymph, it is from the cochlear aqueduct, and this is the ultrafiltrate of CSF. Very important. You'll see this in diagnostic and approach also. Perilymph is for ultrafiltrate of CSF, and perilymph is in between the bony and membranous labyrinth. Okay, perilymph is between the bony and membranous labyrinth, and endolymph is inside the membranous labyrinth. This is about the endolymph and perilymph. Okay, now very important thing, endolymph is rich in potassium. Okay, endolymph is rich in potassium, and perilymph is rich in sodium. Okay, so how I remember is P is there, so potassium is not there. Simple. Perilymph has P here, so potassium is not there. Endolymph has potassium, whereas perilymph, which has P but does not have potassium. So coming to the pathophysiology of Meniere's disease, the first thing is overproduction or malabsorption of endolymph. Okay, if it is produced more and it is not absorbed properly, it causes the enlargement of membranous labyrinth. So because of overproduction or malabsorption, we have endolymphatic hypertension, and if there is endolymphatic hypertension, there is gross enlargement of membranous labyrinth, causing endolymphatic hydrops. Okay, you can see this diagram here. This endolymphatic sac, it will become big. Second thing, now there is damage to organ of corti due to the excessive swelling. Okay, there is excessive swelling, so there can be damage to organ of corti. So there will be decreased hearing loss. And hearing loss is decreased. So there will be distortion of the sound, and this causes the sensory neural hearing loss. Okay, since macular is responsible for both hearing and balance, so there will be some balance disturbance also. And crista is responsible for balance. So if crista is involved, there will be distortion of information, therefore imbalance will be there. Okay, there will be resinous membrane. Okay, due to micro tears in these membrane, there can be sodium potassium imbalance. Okay, sodium can come into the endolymph and potassium can go into the perilymph, so that can happen due to the micro tears. Okay, and due to the malabsorption. Okay, so this will complaints of on and off tinnitus. Okay, so this was about the pathophysiology of the Meniere's disease. Overproduction or malabsorption of endolymph, damage to organ of corti, damage to macula, damage to crista, and then micro tears in the resinous membrane. Okay, and electrolyte imbalance causing on and off tinnitus. So this was about the pathophysiology of Meniere's disease. Coming to types of Meniere's disease, first one we have primary. There is idiopathic. The cause is not known. Secondary we have, it is secondary to infection, trauma, allergy, autoimmune, or any other cause. Third one, there is genetic predisposition, that is chromosome number 6 is also attributed for causing Meniere's disease. Okay. So what are the predisposing factors? The first one, we have allergy, then we have sodium and water retention, hypoadrenalism, hypopituitarism, hypothyroidism. So these are the predisposing factors. Coming to the cardinal features of Meniere's disease, we have already learned VST, vertigo, sensory neural hearing loss, T is tinnitus, and oral fullness. Now coming, let's know about vertigo. What kind and what type of vertigo is there? Here vertigo will last for minutes to hours. Okay, timing of vertigo is very important. So here it will last for minutes to hours. There is severe sudden vertigo accompanied by nystagmus, nausea, vomiting, and vagal disturbances. Okay, what kind of vagal disturbances? Like diarrhea, cold sweat, pallor, bradycardia, and many more. Okay, so vertigo is sudden, severe, accompanied by nystagmus, nausea, vomiting, and vagal disturbances like diarrhea, cold sweat, pallor, and bradycardia. And it was only for a minute to hours. Coming to hearing loss, it is SNHL, sensory neural hearing loss. Sensory neural hearing loss. It is a low frequency hearing loss. Okay, we'll see it why it is so. And because of that, there is distortion of sound that is called diplacusis. Okay, that is little specific to this. Intolerance to loud sounds due to recruitment. Okay, due to recruitment, there is intolerance to loud sounds. Like a normal loud sound will be heard so much loud, very loud. Okay, and it is typically fluctuating. Okay, typically fluctuating type of hearing loss. Tinnitus, there is low pitched roaring type of tinnitus. Sense of oral fullness will be there. What is Tullio's phenomena? Tullio's phenomena is seen here, not only here but some other cases also. It provokes vertigo due to tolerance to loud sound. Okay, vertigo due to intolerance to loud sound. So this was about the cardinal features of Meniere's disease. Why there is low frequency hearing loss? Okay, so for that let's draw a cochlea. Okay, so this is the base of the cochlea. You can see the base of the cochlea, the area is more. Okay, and this is for high frequency, and this is the apex. This is the apex of cochlea. You can see the area is very less. Okay, so any pressure can start creating a micro tears. Okay, and here it is for low frequency. Okay, so in Meniere's disease, the first one to involve is this apex. Therefore, since apex is responsible for the low frequency, and in Meniere's this is involved, so here we have low frequency hearing loss. Okay, let's see here. Scala media at the apex of the cochlea is involved first. Okay, apex of the cochlea, so you can see. And since apex of cochlea recognizes low frequency, and if apex is damaged, therefore the first one is low frequency hearing loss. Now suppose if there was a base of the cochlea involved, then there will be high frequency hearing loss, because according to the tonotopic distribution, base of the cochlea is responsible for high frequency hearing loss. Also, this also I've told you, the apex of the cochlea is narrow as compared to the base, so when pressure increases, apex is the first one to get damaged, therefore there will be low frequency hearing loss. So draw this diagram showing more area in the base and small area in the apex. So this was about why there is low frequency hearing loss. Now coming to the Tullio's phenomena, it is a condition where loud sounds or noise produce vertigo, and it is due to distended saccule lying against stapes footplate. Okay, this is due to distended saccule lying against the stapes footplate. So this will cause vertigo. This condition is seen in perilimb fistula or congenital syphilis or superior semicircular canal dehiscence. Okay, so there are many more conditions for Tullio's phenomenon that you should be knowing: perilimb fistula, congenital syphilis, superior semicircular canal dehiscence. Now coming to the examination of Meniere's disease, very important it is. First thing that we need to do is otoscopy. Okay, otoscopy, since it is an inner ear disease, so otoscopy will always be, most of the time it will be normal. Second, we have to look for the nystagmus. It is seen only during attacks, and fast component is towards the healthy ear. Okay, tuning fork test, it is in favor of SNHL. Okay, then What does it mean in favor of SNHL? It means renase is positive. Okay, that is bone conduction more than air conduction. Okay, Weber's letter lies toward the opposite ear, and ABC is decreased. This is according to tuning fork test. We'll get in favor of SNHL. Then we have to do pure tone audiometry. Characteristic involvement of lower frequencies initially, later flat graph, and then falling type of graph will be seen. Okay, recruitment is positive. I have told you that the smaller like loud sound will be heard as very loud. Okay, due to recruitment. Speech audiometry, mainly to differentiate from retrocochlear lesion like acoustic neuroma, have to be done. Now we have to go for glycerol test. Why is glycerol used? Since glycerol is a dehydrating agent, so when given orally, it reduces the endolymphatic pressure as it absorbs. So it reduces the endolymphatic pressure and improves hearing. So glycerol test is done in Meniere's disease. Caloric test. Okay. So while doing caloric test, there can be canal paresis, decrease or no response of the canal. What is the diagnostic test for Meniere's is electrocochleography. It is very important. The diagnostic test for Meniere's disease is electrocochleography. Here we have summation potential upon action potential is less than 13%. It is normal people. If SP by AP is more than 30%, it is suggestive of Meniere's disease. And if it is more than 40%, it is diagnostic of Meniere's disease. So it is done transtympanically. Electrode is placed inside the promontory and the potentials are obtained. Then we'll come for the audiogram results. There is upsloping type of graph is seen. Okay, low frequencies affected more. Upsloping type of graph is seen. And 3 hours after administration of glycerol, that you know that glycerol will absorb and it will improve the hearing. Audiogram score improves at every frequency, indicating Meniere's disease. So if there is improvement with glycerol, it indicates Meniere's disease. What is role of MRI in gadolinium contrast? So I have already told you that perilymph is ultrafiltrate of CSF. Okay, and this gadolinium stains CSF. Okay, so now you can imagine perilymph is ultrafiltrate of CSF and gadolinium can stain CSF, so it can stain perilymph also. Okay, so normally scala vestibuli and scala tympani is filled with CSF, but it is not seen in scala media. But in Meniere's disease, if there is micro tears in resinous membrane, this perilymph will come out and it can stain. The stained exudate from CSF is seen in all three compartments, even in scala media. That was not normally seen, and because of these micro tears, perilymph coming outside, since perilymph is a CSF ultrafiltrate, so it will also be stained. Okay, so this is the role of MRI gadolinium contrast. Now coming to what are the variants of Meniere's disease. First one, it is cochlear. In cochlear, there will be only cochlear symptoms. Cochlea is mainly for hearing loss, so mainly hearing loss symptoms will be there. More, there will be no vertigo. Vestibular hydrops is the second variant. Here only vestibule. Vestibule is responsible for balance. So mainly vertigo will be there, and there is no cochlear symptoms like lesser of hearing loss but more of vertigo. The third variant is Lermois syndrome. Okay, there I have told you to remember VST. Okay, in a sequence, but here first one is T followed by hearing loss, then followed by vertigo. So this sequence is changed, opposite sequence, that is called Lermois syndrome. Then we have Tumarkin's otolith crisis. Okay, here you have sudden drop attacks. There will be sudden drop attacks without the loss of consciousness, that is Tumarkin's otolith crisis. So 4 variants: cochlear, vestibular hydrops, Lermois syndrome, Tumarkin's otolith crisis. What are the secondary Meniere's? It is due to some disease, maybe congenital and acquired syphilis, Peyer's disease, and post-stapedectomy. So these are the secondary Meniere's. What is the treatment for Meniere's disease? So first let's see about some general measures. Decrease the salt diet to almost 1.5 to 2 gram per day. Stop smoking, as nicotine causes vasospasm and more of that endolymphatic hypertension. Avoid excessive intake of water. Important. Avoid excessive intake of water. Correct hormonal imbalance, that I've told you, that allergy, hypothyroidism, hypopituitarism, you have to correct those imbalances first. Eliminate the allergens, because 50% allergens are found they're the cause. So eliminate the allergen. So this is the general measures. Coming to pharmacological treatment, we can give the vestibular sedatives, vasodilators. Okay, vestibular sedatives we can give is dimenhydrinate, promethazine, and in chronic attack we can give prochlorperazine. Vasodilators that are used usually are carbogen and histamine drip, and in chronic cases we can give beta histine or nicotinic acid. In acute attack we can give atropine also, but in chronic attack we can give diuretics also to reduce the pressure. Then we can go for intratympanic steroids. Very important. This is local acting steroids, therefore be less systematic adverse effect. Okay, to reduce the systemic adverse effect we give local acting steroids, and since it can cross the tympanic membrane and directly go to the middle ear, so there is more concentration of the drug that can reach to the inner ear, and bioavailability will be higher, so we prefer intratympanic steroids through tympanic membrane into the middle ear and then through the rod window to the scala media. So what to do? 0.3 to 0.4 ml of the drug can be given, because this is the holding capacity of the middle ear, and 4 to 6 doses of injection are required. This is about the intratympanic steroids. Okay, so you know about these drugs, that is vestibular sedatives, vasodilators, atropine, diuretics, intratympanic steroids. Now you know about the microcatheter and microbic. These are the drug delivery devices. We can use intratympanic gentamicin, but this is not used regularly. Only in case if there is so much of complications, we have to prevent the complication. But it can cause permanent hearing loss. So our concern is not hearing loss. Our concern is to prevent the complications. So we use gentamicin as a ototoxic drug. Then we have MENIERE'S device. What is MENIERE'S device? It will intermittently pulse pressure, like it will help in the reabsorption of the fluid. As the pressure increases, it starts absorbing. MENIERE'S device, intermittent pulse pressure device. This helps in reabsorption of the fluid. Then we have to go for the surgeries. So here to name few surgeries, we have conservative procedures like that will preserve the hearing loss, or destructive surgeries that destroys the hearing. In conservative procedures, we have vestibular nerve sectioning, we have decompression of endolymphatic sac, endolymphatic shunt can be done, sacculotomy, that is fixed procedure, cardiac procedure can be done, and cochleosacculostomy, that is cochlear duct is punctured to reduce the pressure. So this is the conservative procedure. Here the hearing is preserved, and in complicated cases we have to go for destructive surgery, that is labyrinthectomy. So this is about the management of the Meniere's disease. Okay, so you need to know about the cause, pathophysiology, definitions, types, variants, then management. Examination is very important. So all these things is about the Meniere's disease. Thank you so much.